Okay, so this is Module 4 in class number 3. There is so much in the mood disorders that it took us a few slides to get through it. So we've already gone through the depressive disorders, and now we're going to move on to the other mood disorders, which are bipolar and related disorders. The bipolar and related disorders include your bipolar conditions as well as your cyclothymic disorder. Now, first we're going to start with a general overview of what is required for a bipolar condition, whether bipolar 1 or 2. A bipolar condition generally consists of two things, two poles, depression and mania. In order for there to be a bipolar condition, there must have been a major depressive episode. I'll repeat, a bipolar disorder requires that a major depressive episode must have occurred. That is the case whether the bipolar in question is a bipolar 1 or a bipolar 2. A depressive episode has to have occurred. And now we understand, having gone through the symptomatology for major depressive disorder, we know exactly what a major depressive episode looks like. So for a bipolar 1 disorder, criteria for mania must be met. So you have to have the depressive episode, that's a given, and mania if it's a bipolar 1. What is mania? Mania is this persistently elevated and expansive mood. It can be irritability as well, but with this goal-directed energy that's going to last for at least 1 week. So we know for a major depressive episode, it has to be in place for how long? Right, at least 2 weeks. And then we have the presence in a bipolar 1 of a manic episode, which is lasting at least 1 week. Okay, we're going to come back to the mania. I want to, kind of sidebar here and bring your mind to colloquial language. When people say, yeah, I'm just up and down all day, I'm up and down all day, they are not describing a bipolar condition because your depression needs to be in place for at least 2 weeks, where for most of the day, nearly every day, the primary feature is the sadness or the grief, right? Then that gets exchanged for this elevated and expansive mood and energy. So when you think about a bipolar disorder, it is not a happy, sad valence. It is more of an energy valence because the mania is this expansive energy and mood that is happening as if the person is running on a battery, right? And the opposite of that is a depressed mood, a slowing. So it's this energy valence that we're talking about. So the mania that's lasting for at least a week, 4 of the following have to occur during that time. There's an inflated sense of self. There is no need, or at least a decreased need for sleep. When the person is talking and thinking, it is at a pressured and racing pace. The person is easily distracted. Their mind is situated on the thing that they have to do, very goal-directed. And There is involvement in activities that could be problematic, have significant, severe, painful consequences. For instance, overspending, right? That can have severe and painful consequences. Also, during this time period, there's the mood disturbance that is creating marked impairment. Remember, we learned this at the beginning. In order to be a disorder, it has to create some sort of impairment in the usual functionality of the individual. And whatever is going on in this depressed mood and then this high energy mood of mania, it is not attributable to a substance. That means that if we notice this intensity, either on the mania side or on the depressed side, simply because of a substance, we would go with the substance. So this is not attributable to a substance. This is not some sort of a substance induced or just a substance disorder. Substances have nothing to do with a bipolar disorder. Okay, so just to recap, a bipolar disorder requires the presence of a major depressive disorder. For a bipolar 1 disorder to be in place, mania has to be present, and that has to be in place for at least 1 week. We are talking energy valence. If we're talking about a bipolar 2 disorder, again, there has to be a depressive episode, but criteria for hypomania has to be met. The hypomanic symptoms are the same as the manic symptoms. However, the intensity and duration is much shorter. We're talking about 4 days versus a week. We're talking about sleeping more, not going nearly without sleep, right? Not as elevated of a sense of self. The thoughts and speech not as pressured, but faster than what is typical for that person. When we are diagnosing a bipolar disorder, similar to how we diagnose a major depressive disorder, we are going to indicate if the current or most recent episode is manic, hypomanic, or depressed. Okay? We're going to indicate the severity if we think it's mild, moderate, or severe. We're going to indicate whether or not there is the presence of psychosis. And eventually, when we get to psychotic disorders, we can flesh out what psychosis really means. We're going to indicate the remission status. Remember, we talked about that. Is it in partial remission, sustained remission, full remission, right? Are there any other specifiers? So in this instance, we would say the person has a bipolar 1 disorder. The current or most recent episode is manic. This seems moderate in severity, without psychosis, and with catatonia. Okay? So again, bipolar disorders all require the major depressive episode. The distinguishment between a bipolar 1 and a bipolar 2 is the presence of mania versus hypomania. This is not a happy, sad disorder. This is a disorder more along the lines of energy and going from having very little and depressed energy to having elevated, expansive energy and a greater sense, an inflated sense of self. This particular disorder can span the lifetime, but it usually presents in late teens, early 20s. It can have onset much later, 60s or 70s, but that would usually be unusual and should have us considering in that it usually onsets at 18. Is there a medical condition that might be prompting this particular condition of depression and mania to present? Rapid cycling. Again, I'm going to go back to colloquial language. When people say, "Oh, I'm up and down every day, I'm up and down." Again, even with a bipolar condition, there is no up and down in the same day in that way. A person can be sad for most of the day, for nearly every day, but on the other part of that day that they are not sad and in that true depressive state, they are not swinging up to mania, right? These are happening in succession, a depression and a mania, which is why you would say the most recent episode and then you identify it. These are not happening simultaneously, okay? But when we are talking about rapid cycling, what we mean is that a person has had 4 or more episodes in a single year, 4 or more episodes of their depression and mania or depression and hypomania. That has occurred 4 or more times. Okay? Family history is important. So you want to get family history about mental health conditions. If there is a family history of a bipolar disorder, there is a 10 times greater risk that other family members will have bipolar disorder as well. If you have a parent who has a bipolar disorder, there is a 10 times greater chance that their child will suffer with bipolar disorder as well. When we're talking about the rapid cycling, 4 times or more in a year, that is more common in females. Mixed states occur equally between males and females. Then we have the 15-fold increase for suicidality. That is significant, right? What that means is if you are working with an individual and you know that they have a bipolar disorder, that means that you absolutely should be thinking about frequently assessing for suicidality as you start to notice shifts in the person's demeanor. Because again, going back to the diagnostic criteria, there are major and significant consequences that happen with an individual who has a bipolar disorder. For many individuals who have a bipolar 1 disorder, hospitalization is rather common. Medication is also common. So this isn't a thing that a person has that level of energy for at least a week and they're not getting into some sort of trouble. That's not the sort of thing that a person can sort of pull themselves back from. So a bipolar disorder usually has medication attached, but often people don't realize a bipolar condition before damage gets created, and so that can lead to the increase in suicidality. It is necessary, again going back to the bipolar 2 disorder, it is necessary to meet criteria for a current or past hypomanic episode and criteria for a current or past depressive episode. Bipolar 2 disorder can start in late adolescence, just like with bipolar 2, but it usually begins with a depressive episode. And in that, it is lesser intensity than a bipolar 1, the number of lifetime episodes is greater than a bipolar 1 disorder. So individuals who have bipolar 2, where they have some sense of expanded or elevated mood, but not to the degree where medication is absolute, where hospitalization may be required, where they are destroying their finances, for instance. Whereas that may not be occurring, it is the case that there could be more hypomanic episodes that correspond with the depressive ones. Psychosis does not occur during hypomanic episodes. Remember, going back to bipolar 2, going back to bipolar 1, you would indicate severity with or without psychosis. There is no psychosis with a bipolar 2 disorder. If we're thinking that there's psychosis, we may want to reevaluate whether or not what we evidenced for this person was only mania, or was it actually, whether or not it was hypomania or was it actually mania. Okay? There are other differentials that, will come up later on, but again, there is no psychosis during a hypomanic episode. There could be psychosis with depressive episodes, but there is no psychosis with a bipolar 2 during a hypomanic episode. Bipolar 2 is more prevalent in women, and interestingly can be triggered by childbirth, so early postpartum. Okay, so that postpartum depression, since for some the first episode in a bipolar 2 may begin with the depressive episode, right? We are on the lookout for potentially the presence of a hypomanic or manic episode, just in general, right? So when a client comes in and they're talking to you about depression and you're just like, yep, there it is, we do want to do a full history and ask, are there times when you feel like you have so much energy that you don't need to rest and your thoughts are coming really rapidly and those sort of things? If they say, no, I've not had that. I've not been hypersexual, or I've not overspent, or those sort of things, been reckless with my money during certain periods of time that would suggest a hypomania or a mania, then we can have some certainty that what we are dealing with is a unipolar depression and not um, the depressive side of a bipolar disorder, right? But you have to ask and you have to delve into that, because individuals with bipolar disorder have a lot of goal-directed behavior, right? So that means that they tend to get a lot of work done during that time. So individuals who have had bipolar disorder have said, I rather enjoy that. I like being in that productive state of who I am versus that other depressive side of who I am. So they don't see it as a need or a cry for help when they can now focus on getting things done. But there may not be the recognition of the expansive and risky nature of that goal-directed behavior, okay? But that's not usually what brings people into therapy, because that's the time where they feel good, okay? So that's also something to keep in mind. Most people will come in during the depressive phase and not during the manic or hypomanic phase. Going back to the Call Me Crazy film shorts, Grace and Robin are two characters that really exemplify the bipolar condition, and you can watch it and sort of determine in your own assessment whether or not you think this is a bipolar 1 or a bipolar 2. I have included here some thoughts for you to consider while you're watching. In your observations of Robin, who is the mother, what symptoms of bipolar disorder are evident? Okay. And do you think this is a bipolar 1 or a bipolar 2? So you're just sort of observing her behaviors and trying to figure that out. Consider doing a mental status exam of Robin based on what it is you're noticing. Pay attention to the familial impact of the disorder, particularly on Grace, the daughter, and then look at your own observations of Grace. What are you noticing in her as a function of her mother's disorder? Okay. As you're watching the scene, you will notice that Grace starts to pick up on things that give her indication we are here again. So, what are some of those environmental clues and triggers that you see Grace responding to? And then think about the availability of social supports for both. This is a debilitating disorder because of the manic and hypomanic sides, even the depressive side. So in this instance, the person is not just dealing with one, they're dealing with both. So whereas they might get past a depressive episode, instead of going into their usual neurotypical state of being, they may shift into the manic side, okay, or hypomanic side. So social supports become that much more important, and we want to make sure that we're asking about that. But what are they for Grace and for Robin? This can be discussion again that you just sort of do with yourself, but really I think it's helpful as a beginning therapist to get with somebody and sort of have this discussion. Let's see if if I can maybe add something to help differentiate a little bit better mania from hypomania. Again, many of the symptoms are the same as I listed on the slide. I listed the symptoms for mania because the DSM is going to list the same symptoms for hypomania. However, severity distinguishes the two. Both involve mood and behavior changes apart from whatever is typical for that person. But mania is so severe, right, that it impacts that person's ability to carry out their usual activities, and often hospitalization is the result. Okay, so when people say, oh, I'm bipolar, and there hasn't been a hospitalization, I'm wondering whether or not we have a bipolar 2, because the severity of the depression and the severity of the mania is such that it really does impact the person's ability to carry out their usual activities, okay? In hypomania, usual activities generally can still be conducted, right? There's excessive spending, but savings isn't depleted, okay? Mania can coincide with delusions and psychosis, whereas hypomania, this would not be the case. Okay, so again, its severity is lessened. There is psychosis with mania and not with hypomania. The person can still carry out their usual activities without disruption in a hypomanic state, not necessarily so in a manic state. So here I've given just a few more indications so that you can understand that a little bit better. Mania is uncontrolled, right? It's out of control energy. And hypomania is not out of control. It is higher excitability, but it's not out of control. It's a higher than usual regard for self. It's not an unrealistic perspective about self. Okay? Mania without social inhibition. Hypomania, I'm less restrained, right? Far less restrained than I would usually be, not without inhibition on a manic side. Okay? The risks are extreme and reckless on the manic side, less regard for injury on a hypomanic side, for example. Okay? As well as sex drive being higher than usual versus extreme and reckless sexuality that might be present on a hypomanic side. Okay? Less need for sleep or not sleeping. Um, don't need as much sleep on a manic side or hypomanic side. Okay? Hopefully that helps to differentiate those. Okay, so we've talked about the depressive disorders. We've talked about the bipolar disorders, and now we're talking about the part that says and related disorders. And that's what brings us to cyclothymia. So what is cyclothymia? Cyclothymia is akin to a bipolar disorder, but just like major depressive disorder has persistent depressive disorder, which is a chronic version of major depression, cyclothymia is somewhat like that for the bipolar disorders. The symptoms are present across a 2-year period, at least 4 or more sequences. So remember the rapid cycling. So for a cyclothymia, there have been that 4 or more sequences. However, neither full symptom nor duration are met for the hypomanic or the depressive experiences. They had the depression, but it wasn't at least 2 weeks. They had the hypomania, sort of, not quite as intense as we might imagine a hypomania would be. Okay? The symptoms are present for about 1 year, and the person has not been without symptoms for more than 2 months, suggesting some euthymia, some usual normal in quotes mood. Okay? A bipolar 2 disorder is distinct from a cyclothymia because of the presence of a major depressive episode. Bipolar disorders have to have the major depressive episodes. Notice here, in the cyclothymia, we've indicated that full criteria is not met for the depressive episode or for the hypomanic. So we are not confusing a bipolar disorder with a cyclothymia, because if depressive disorder is in place, we're going to go with bipolar. We could be trying to figure out bipolar 2 from a cyclothymia. However, that would mean that full criteria was met for a hypomanic episode for it to be a bipolar 2. Here we are saying we did not meet full criteria for either of those, for the bipolar 2 hypomania or the depression that's necessary. Finally, if a major depressive episode or a hypomanic episode is experienced, then the diagnosis is changed either to major depressive disorder or bipolar 2 disorder. So if we have what we think is a cyclothymia going on and the person falls into a major depressive episode and we don't see Any signs of lesser hypomania, we're just going to go with a major depression. However, if we do see a full hypomanic episode, we shift to bipolar disorder. Okay, so that's going to do it for our mood disorders. We've talked about our depressive disorders. We've talked about our bipolar disorders. We've distinguished mania from hypomania. And then we've talked about cyclothymia. Okay, so while the module 2 for this section is not on video, it is no less important. It gives you some cultural context for mood disorders. I really encourage that you not skip over that module because it is all important information that's going to be needed for diagnosing. My final statements are, you can see how I'm wanting you to take 1 week at a time. There is so much to get your arms around with each section of disorders that I don't want you working ahead. The mood disorders are pretty dense. There's a lot going on here to think about. And so, again, just sort of go over these, but think about how these may come together and be shaped, and how important history is, that intake interview is, in getting at the symptoms that are needed for diagnostic clarification.